My dear students, okay, so today we're going to discuss about the the Erb palsy and the Klumpke's palsy, the brachial plexus injury. Let's see this question here. In this question, we have a 1-day-old baby, and he has a normal delivery, right, with the shoulder dystocia in the question. And he has the presentation is right arm is adducted and internally rotated with forearm extension, right? So let's see the points over here, right? So these points are highlighted. So this is the cause of shoulder dystocia, and this is the presentation after the injury. Okay, so here we care two things. One, that is the cause. The cause is shoulder dystocia, and we see the presentation, right? The presentation we have here is number one, adduction of the arm. Number two, internal or medial rotation. Number three, presentation is forearm extension. That means the elbow extension, right? So these two things, one is the cause and another one is what? The presentation. So these two things we have to be careful. So if we see these two things, we can diagnose what's the problem in this baby, right? So from this, what they can ask you is that question number one, what's the location of injury, right? Question number two, what is this pathology called, right? So what's the diagnosis? So once we discuss the injuries, then we will come to know the answer of this question. So let's go forward. So this is our brachial plexus. Brachial plexus has the root value C5, C6, C7, C8 and T1. That's the standard value, C5 to T1. If it is prefix, it is above C5 as like C3 and C4. If it is postfix, then the root value is below T1, right? So that is 1% of the cases. So this is the brachial plexus, and this brachial plexus, these are the composition, right? Rover, Turner, rings, cold, beer, right? So that means the root, the cord, the trunk, the division, right? Division should be here, the cord and the branches, right? So this my writing is shifted over this side. So this should be the root here, trunk here, division here, cord, and then the branches. Okay, so these are the composition of the brachial plexus. And the brachial plexus injury classification, like in the last lecture we did some of the classification of the brachial plexus injury. So number one, we said brachial plexus root injury. Number two, we said the brachial plexus trunk injury. And number three, we said the brachial plexus, the cord and the branches injury, right? So these are the three types of brachial plexus injury. So among these two, 1 and 2, these are the supraclavicular injury, and this one was the infraclavicular injury, right? So this is infraclavicular, this and these two are the supraclavicular, right? So these are the supraclavicular injuries. After this, from the root, the injury in the root, we divide this into two types. One is, let's make it like this, okay, little bigger one this one, another one this one. So this one was the, what is this one, pre-ganglionic injury. Another one was post ganglionic injury. Yes. And what was that pre-ganglionic and post-ganglionic injury? Now let's discuss about the pre-ganglionic injury. Pre-ganglionic means what was the location? The location was above the dorsal root ganglion. That was the location, right? And the dorsal root ganglion, hope you understand, right? And what were the presentations, right? So in the presentations, it involved the long thoracic nerve. If it is long thoracic nerve is involved, the patient presents with the medial winging of scapula. It may involve the dorsal scapular nerve. If it is so, then the patient present with what? The lateral winging of scapula, right? It involves the sympathetic chain ganglion. Then patient presents with the Horner syndrome. Horner syndrome means, if you remember, we had three things like anhidrosis, ptosis, and meiosis. So these were the presentations. Similarly, we had the involvement of the phrenic nerve. Phrenic nerve that will produce the hemidiaphragm. That means elevation of the diaphragm, that we discussed last class. So please go to the previous videos as well. And the another thing, we did some test for this, and in this test we did one test as the electromyogram of paraspinal muscles of the cervical region, right? And this electromyography was negative, right? And another test we did was the histamine test. That means we injected the histamine and it was producing three features, that is the flares, the flush, and then the wheals, right? All of those were present positive, right? So that means it was not affected, right? So those were the findings in case of this preganglionic lesions. And another point was the flail arm was also the another presentation, like FLIAR, flail arm. Flail arm means the arm becomes flaccid and wasting of the muscles. And then in the postganglionic injury, the location of the postganglionic injury was the below DRG, dorsal root ganglia, right? Where is the dorsal root ganglia? I hope you know. If not, then I'll draw the picture after some time and show you. So that is below the dorsal root ganglia, and here the long thoracic nerve was intact, and here our dorsal scapular nerve also intact. And the differentiating point here we did was, in the differentiating point we did the EMG of the cervical paraspinal muscle. They were also normal, but we did the histamine test. In the histamine test there was wheal positive, there was flush positive, but the flare was lost, the flare was negative, right? So that was the distinguishing features between the preganglionic and then the postganglionic injuries. So after doing this, and then we also discuss about the trunk injury. In the trunk we divide into two, that was the upper trunk and then the lower trunk, right? In the upper trunk it was involving the C5 and C6 root values. Lower trunk was involving C8 and T1 root values, right? So C5 and C6 it was called the Off's palsy, and C8 and T1 it was called the Klumpke's palsy, right? And how we understand those that there was a trick, like we said E comes first then K. That's why E is Off's palsy, which is above, right, upper trunk, and then K comes below that, so that's why it's a lower trunk. Below means lower, right? So Klumpke's palsy we discussed like this. And then these are the questions in the exam. These are also the questions. So please remember this one, right? So in the cord or branches injuries we divide them into three types, right? So that was the very high lesion, another was the high lesion, and then the another was low lesion. Very high lesion means it was involving the axilla, that means the injury was in the axilla. High lesion means the injury was in the arm. Low lesion was in the elbow and below that, right? So that's what we discussed last class. Today we are going to discuss in more details of this trunk injuries, right? So that is the Off's palsy and then the Klumpke's palsy. Now let's go forward. These are the dermatomes, like the medial side of your arm, the palm is supplied by the C8, the middle of your palm is supplied by C7, and above this one the lateral side is supplied by the C6, right? So C7, C8, that's the ulnar nervation, and this one C6, this is coming from the median Alright, so these are the dermatomal distributions here, and you can see here the radial nerve supplement, the median nerve supply, and then the ulnar nerve supplies. These are the cutaneous supplies. Okay. Now let's go to the Ops palsy. The Ops palsy, first of all, let's know about the Ops palsy. What is the location of the Ops palsy? To know the location of the Ops palsy, let's make the picture like this. This picture has these two roots and going like this dividing this way. One nerve comes over here, next nerve comes over here, right? So this is my C5 and this is my C6. This point is called the Ops point. This is called what? The Ops point. This is called the Ops point. So this Ops point involves C5 root, C6 root, and this nerve which is going up. This nerve is my that is my suprascapular nerve, and this nerve which is going down, this is my nerve to subclavius, right? So it is involving how many things? Look at here, 1 2 3 4 5 6, right? So Ops point is the meeting point of 6 nerve. Ops point is the meeting point of meeting, meeting point of 6 nerves. This is called what? The Ops point, meeting point of 6 nerves. That is called Ops point, and the injury in this point, it involves these 6 nerves, right? So it involves the location this, right? So this is my upper trunk. And what's the root value it involved? That is C5 and C6, right? If it involves the C5 and C6, it involves the many nerves, right? So what are the nerves involved? We'll discuss after some time. So what are the etiologies of my Ops palsy? So the etiologies are, number 1, VACC vacuum delivery, right? That you can see here, right? So this we can use the vacuum to pull the head of this baby, right? Another one is, you can see how the patient fall down over here, yes or no? So this is the way how the patient fall. So you can see the neck and shoulder, this is extended, here also extended. So this is hyperextension of your neck, this is the hyperextension of your neck. So what happens here? Here the shoulder is pushed downward forcefully. So here we have the forceful downward displacement of shoulder, right? So here vacuum delivery, we said vacuum delivery means, look at here, why we are pulling this baby this way, because sometimes the shoulder get obstruct over here. So to get this shoulder, get rid from this obstruction, we pull the baby like this, right? So this shoulder obstruction over here, right, this is called the shoulder dystocia. What do we call this one? This is called the shoulder dystocia. So this is the shoulder dystocia. Anyway, by both of these, what is doing there? There the neck is hyper extended, right? So this neck hyperextension, it causes the upper trunk injury. Upper trunk injury means this produces the Ops palsy, right? This is what we are discussing. So these are the causes. So what are the nerves involved over here? The nerves involved is discussed in very short. Like we have this is my C5, this is my C6, yes or no? So the C5 C6 goes like this, and then here it makes one branch over here, this branch over here, and here also we are getting the another nerve over here like this and like this, right? So it is going this way, it is going this way, and it is going this way, right? So this is 5 6 C7 C8 and T1, yes or no? So we have the injury over here. If it involve the injury over here, it is involving C5 and C6 root. That means it is involving the suprascapular nerve. It is involving the nerve to subclavius, yes or no? And it is also involving, if you remember here, we had the two nerve going like this and like this. This nerve was upper subscapular nerve, that was lower subscapular nerve, and here we have the axillary nerve, right? So this axillary nerve root value is C5 C6. Upper subscapular nerve root value is C5 C6. Lower subscapular nerve root value is C5 C6. Okay, and here this one I draw over here. This is my musculocutaneous nerve. This long thoracic nerve. This long thoracic nerve root value is C5 C6 and C7, right? And here my suprascapular nerve root value is C5 C6, and here now to subclavius is also C5 C6, right? And if you remember here, this was my the superior or the lateral cord. Finally it forms this lateral cord. It gives me the long musculocutaneous nerve. Musculocutaneous nerve root value is C5 to C7, C5 6 7, right? So this also involves the 5 6. So how many nerves it involves? Look at here: 1 2 3 4 5. Here also some root involved, 6. Here also some root involved, plus we have the radial nerve. Radial nerve root value is C5 to T1, plus we have the median nerve, its root value is C5 to T1. So it is also involved partially, it is also involved partially, right? So these are the nerves involved, so we have to know this one, partial involvement, right? Here also partial involvement, this is full involvement, full, right? This is also full, this is also full involvement, this is also full involvement, because C5 C6 root values they have. So if these all the nerves are involved, what's the presentation? Let's see the presentation in this baby. How is this presented, right? So this is the shoulder joint. Shoulder joint is adducted. This is adducted, and it is rotated medially. And here the elbow is extended, right? Extended, and you can see here the wrist is flexed, fingers are also flexed, right? So that's the presentation. So how is it presented? Look at here. This is called the waiter's tip. That means my arm is adducted. Arm is adducted because of the nerves involved, and you can see it is medially rotated. And you can see here the elbow is extended, right? And what happens here, plus if the C7 is involved, usually Off's palsy has C6 and C5 only involvement, yes or no? So if the C7 is involved, then what happens? Wrist is flexed and fingers are also flexed, right? So this all presentation is called what? The waiter's tip presentation. And look at here, the point we have to understand here, why the arm is adducted, because it is involving what? It is involving the axillary nerve. Axillary nerve is damaging my deltoid, and it is also involving what? It is also involving my suprascapular nerve. Suprascapular nerve is supplying my supraspinatus muscle, right? So that these two muscles are involved, so we cannot do the abduction. That's why it is adducted, right? Similarly, it is medially rotated because the lateral rotating muscles are involved, and here we have the strong pectoralis major muscle pulling medially. Major muscle which is pulling medially, that's why it is medially rotated. Elbow is extended because we have the elbow flexors that is supplied by the musculocutaneous nerve which are involved, right? So that's why this is the presentation of our the Off's palsy. Atrophy and weakness, so finally it causes the deltoid muscle weakness, that is supplied by axillary nerve by the root value C5 and C6. Plus it also negatively affect the biceps brachii muscle. Biceps brachii. Biceps brachii muscle is supplied by the musculocutaneous nerve. Musculocutaneous nerve root value is C5 to C7, but biceps brachii is supplied by the root value C5 and C6 of the musculocutaneous nerve. That's why they can ask you the question in the exam. The muscle which are negatively affected, that is the deltoid muscle and then the biceps brachii muscle. So please remember this one, they are the negatively affected muscles. This is the question in the exam. These are also the questions in the exam, the presentations of the Off's palsy, right? Let's go to the Klumpke's palsy. In the Klumpke's palsy, let's understand the location over here. To understand the location, it's very simple. Like we have this and this two roots going like this, right? Dividing this way. So this is my C8, this is my T1, and these are the anterior and posterior divisions, right? Anterior, posterior, divisions. So the injury is over here, right? So this is my what? The lower trunk injury. So the root value it involve, what are the roots it involve? It involves the root, this two. So this two means what? That is C8 and T1. These two roots are involved. And what are the etiologies? The etiology we can understand over here. We can see one person, right? So he is hanging over the tree, number one. Number two, the baby has the hand presentation and the nurse is pulling the baby by the hand. And here we have, you can see this white, this is called the Pancoast tumor. Pancoast tumor means the tumor present over the apex of the lungs. So see, this tumor is compressing my brachial plexus nerves. They're coming over here, right? So that, what are the etiologies? In the etiology, we can see the etiology number one. What is the number one etiology? That is the breech presentation. Breech presentation, where the presenting part is the hand. That's why the sister is pulling baby by hand, right? So that is pulling baby by hand, right, during the delivery. And another point is that person is hanging over here. That means hanging over the tree, hanging or grabbing the tree branch, right? So another third point is what? This is, we said, as a Pancoast tumor. What is this called? Pancoast, Pancoast tumor. Pancoast tumor means tumor at lungs apex. Okay, so this tumor not only compress the brachial plexus, it compress brachial plexus plus it compress the vessels as well. Okay, so this we will discuss after some time, as this Pancoast tumor is one of the cause for this the Klumpke's palsy, right? So finally, all these two causes, what they are doing, these two they are doing, look at here, what's going on here. This is the abduction, hyper abduction of my arm. So both of these leading to hyper abduction of arm, right? So this is causing the injury to my what? Lower trunk of brachial plexus. So remember this one, and this is also compressing the lower trunk of brachial plexus, right? So this is causing the Klumpke's palsy. So what's the presentation? The presentation is, remember, it is involving my root value C8 and T1. C8 and T1 means my ulnar nerve, right? Plus some part of the median nerve as well, right? So if it is involved, so it negatively affect the intrinsic muscles of hand. Intrinsic muscles means that is the lumbricals, and it also affect the interosseous muscle. So both of these are affected. Because of this, the patient present with, look at here, the patient has the wrist flexion, and after the wrist flexion you can see over here the extension of the metacarpophalangeal joint, right? So we have the metacarpophalangeal joint extension and interphalangeal joint flexion, right? So it will come with the wrist flexion, MCP extension, and interphalangeal joint, IPJ, interphalangeal joint, that is proximal and distal interphalangeal joint, right? So we have the proximal and distal interphalangeal joint, they are flexed. So this presentation is called the claw hand presentation. What is this called? Claw hand presentation. So remember this one, claw hand. Claw hand is the presentation in case of what? The Klumpke's palsy. Plus here the patient may have the pain over the 4th and 5th digit, right? Like if you have the Pancoast tumor, yes or no? Because 4th and 5th digit, they are supplied by the ulnar nerve, right? So we should remember pain over this 4th and 5th digit. Is that okay? So these are the presentations of the Klumpke's palsy. Some point over the thoracic outlet syndrome, because this Pancoast tumor produces the thoracic outlet syndrome. What is thoracic outlet syndrome? Thoracic outlet means we can see here, from here, the major vessel and then the brachial plexus nerve, they get exit from the thorax to the arm. That's why we say this is thoracic outlet. This point is called what? Thoracic outlet. So in this thoracic outlet, if we have something, that something can compress these vessels and nerve, this produces the nerve symptoms and vessel symptoms in the upper limb. That is called what? Thoracic outlet syndrome, right? So two of the major cause for this thoracic outlet syndrome is, number one, Pancoast tumor, as we discussed. That means the lungs apex tumor, okay, that can compress my these vessels and nerves. And another cause is that the cervical rib, that is cervical rib. Cervical rib means that is the extra rib. Usually our rib originate from T1 to T12, that's the normal ribs, but in case of cervical rib, the ribs originate from the C7, right? That's the extra rib we have. So if you have the extra rib, that will compress the blood vessels and then the nerves in this area. That's why it present with two kind of presentations, right? Two kind of presentations. One vascular presentation, another one is what? The nerve presentations, okay? That means the nerve deficit and then the vessel deficits, right? So that's what we call as a thoracic outlet syndrome. So this is the thoracic outlet from where we have the nerve and then the vessels. That means the important neurovascular structures, they exit to the upper limb. That's why we call this is thoracic outlet. Something is exiting from the thorax. That's why it's called thoracic outlet. Here you can see this is the location where we have the Pancoast tumor, right? So what's the location of the lesion? The location of the lesion is, we understand it is causing the lower trunk injury. Lower trunk injury means it is producing what? Klumpke's palsy. So please remember, if this Klumpke's palsy is because of the thoracic outlet syndrome, it produces the vascular symptoms as well. Look at here, we have here the cervical rib. You can see the extra rib over here. This is first rib, second, third, fourth, fifth ribs going like this, but this rib is the extra rib. It is originating from the C7. Look at here, this is the C7 transverse process, okay? So this is my extra rib, this is also my extra rib on this side. So these ribs are called what? The cervical ribs. And because of these ribs, you can see here we have an extra rib over here. It can compress the blood vessel and then it produces the aneurysm, the defect here, okay? So what's the presentation? The presentation is, one, it produces as a Klumpke's palsy. Another, it produces the vascular symptoms. Klumpke's palsy means we know already. That means what? The claw hand, right? Plus it will have the 4th and 5th finger pain and numbness, right? So vascular symptom means, look at here, we can see in this picture the bluish discoloration, right? That means if these vessels are compressed over here by this, the extra cervical rib, or because of this Pancoast tumor, anyway, right? So if this the vessel is compressed over here, then there will be the oxygenation problem in the upper limb, right? That's why the palm will present with the bluish discoloration, cyanosis, right? So you will have what? you will have the cyanosis, cyanosis, cyanosis of your palm and fingers, right? And plus you may have the radial pulsation that will be deficit or decreased, right? And you may have the edema as well, edema, because you have what the vein also compressed. So if you have the vein compression, then the venous return will be decreased, so that you will have what, the edema. Plus the pain will aggravate on this elevation. If you elevate this one, more compression. If more compression, more symptoms, right? So this is about the thoracic outlet syndrome. So by the way, we finished this, the Erb's palsy and then the Klumpke's palsy. Now let's solve some of the questions very quickly. All of the following muscles undergo paralysis after injury to the C5 and C6 spinal nerves except C5 and C6 means what? Bicep is supplied by musculocutaneous nerve. Coracobrachialis, musculocutaneous nerve. Brachialis, musculocutaneous nerve. Brachioradialis, that is a radial nerve. Radial nerve root value is C5 to T1. Musculocutaneous C5 to C7, C5 to C7, C5 to C7, right? So here we have to understand all the following muscles undergo paralysis after an injury to C5 and C6 spinal nerves except, that means bicep, injury to C5, C6, right? So bicep is supplied by C5, C6. Brachialis supplied by C5, C6. Okay, though the musculocutaneous nerve root value is C5 to C7, the fibers going to brachialis is only C5, C6. The fiber going to biceps is also only C5, C6. Brachioradialis radial nerve, that is C5 to T1, but the fibers going to brachioradialis is C5 and C6. But here coracobrachialis is supplied by C5, C6 and C7. That's why if we have this C5, C6 root value involved, C7 is not involved. That's why coracobrachialis is not paralyzed. Now let's go to the next question. Injury to the upper trunk of the brachial plexus results in upper trunk, that means C5 and C6, that means the Erb's palsy, right? So Erb's palsy results in supination of the arm. It should be pronation, right? External rotation, no, it should be internal rotation, right? So that means internal rotation. Internal rotation means that medial rotation, okay? And inability to initiate the abduction, that is true because it is involving what? It is involving my deltoid muscle and supraspinatus muscle, right? So that should be true. And decreased sensation on medial side of the hand, maybe that is not true. That is by the ulnar nerve. And ulnar nerve is C8 and T1, not the C5, C6. Paralysis of the deltoid muscle, that should be true because it is involving the axillary nerve, right? So that is C5 and C6. So the answer should be what? C and E. Question number 3. True about the upper trunk of brachial plexus. So upper trunk of brachial plexus is C5 and C6, right? Carries root value from C5, C6, C7. That's wrong because it is only C5 and C6. Can be blocked medial to scalenus anterior muscle. So where is the scalenus anterior muscle? These are the two ribs we have, and from the first rib we have the scalenus anterior and scalenus medial, and here we have the scalenus posterior. Yes or no? So these are the vertebral bodies, right? So these are my vertebral bodies. Yes or no? And this is my scalenus anterior, this is my scalene medial, this is my scalene posterior. And where is the brachial plexus? My brachial plexus is present in this region. That means it is present here. Okay, sorry, let me clean this one. It is present over here. That means between the scalene anterior and scalene medial. So this is my brachial plexus. Okay, so this is my brachial plexus between the scalene anterior and scalene medial. This is called the anterior scalene triangle. That means the carries root value, that is wrong. Can be blocked medial to scalene anterior muscle. No, that is it is lateral to scalene anterior. This is my scalene anterior muscle, scalene anterior, and it is lateral to scalene anterior. So that should be wrong. Long thoracic nerve arises from it. That means upper trunk, right? So upper trunk, the long thoracic nerve arises from what? The C5, C6, C7. So upper trunk has only C5 and C6. So that should be also wrong. Lesion leads to partial injury to radial nerve. Yes, we discussed because C5 to T1 is radial nerve, and it involves the C5 and C6. That's why we say it's a partial injury to the radial nerve. Let's go to question number 4. False regarding Klumpke's paralysis. Klumpke's paralysis means it's involving C8 to T1. If it is involving C8 to T1, is it producing the claw hand deformity? Yes. Intrinsic muscles of the hand involved? Yes, that's true. Horner syndrome, is it producing? Yes or no? That may be the question mark. Upper trunk of brachial plexus involved? No, that is the lower trunk, right? So it's asking the false regarding the Klumpke's palsy. So we can say this is false, right? This is false. D is our answer. Horner syndrome may be if it involves the T1, because T1 has this sympathetic nerve root, right? That's why Horner syndrome can be produced by the Klumpke's palsy. Question number 5. A 19-year-old boy fell from the motorbike on his shoulder. The doctor diagnosed him a case of ops paralysis. That means, let's see, that is C5 and C6 involved, right? The following signs and symptoms will be observed except, that means ops palsy. What will be the ops palsy? There will be the pronation, there will be the medial rotation, there will be the elbow extension, and there will be the adduction. So these are the findings. Let's see. Loss of abduction at the shoulder joint. That is true. Yes, loss of abduction. That's why it is adducted. That's it. That is true, because the involvement of the deltoid muscle and then the supraspinatus muscle. Loss of the lateral rotation. That is true. That's why it is medially rotated. Loss of pronation at the radioulnar joint. Yes or no? No, because it is pronated. So there should be loss of supination. Loss of supination. Loss of flexion at the elbow joint. Yes, because it is extended, right? So that's why the answer should be what? Loss of pronation, because it is pronated. There should be the loss of supination, right? So that's the answer. Question number 6. 6 year. A young boy who was driving motorcycle at a high speed collided with a tree and was thrown on his right shoulder. Though there was no fracture, his right arm was medially rotated. Let's see here, medially rotated, and forearm pronated. So medial rotation, pronation. The following facts concerning this patient are correct except, that means it has medial rotation and pronation. That means it is about the ops palsy. It is about the ops palsy. So what is false in ops palsy? The injury was at ops point. That is true, right? A lesion of C5 and C6 was present. That's true. A median and ulnar nerves were affected. That is false. So that should be the answer, because it is involving C5 and C6, right? C5 and C6 doesn't mean median and ulnar nerve, right? Supraspinatus, infraspinatus, subclavius, and biceps brachii are involved. That's true. Question number 7. Concerning brachial plexus, which of the following facts are true? That we know already. Formed by the spinal nerve C5, C7. That's wrong, because it is C5 to T1, right? Most common site of injury is upper trunk. That is very true. Ops palsy is the most common injury to brachial plexus. Please remember this one. Injury may occur during breech delivery. Yeah, that's true. Breech delivery, yes or no? That we discussed already. Radial nerve is branch of medial cord. Radial nerve is branch of medial cord. Is this true? Let's see here. It's going like this. It's going like this. Yes or no? It is dividing. Yes or no? And here we are having the posterior cord. From the posterior cord we have the axillary nerve and we have the radial nerve, right? So it's a branch of posterior cord, not the branch of medial cord. So that should be wrong. Lower trunk injury results in hand deformity. Yeah, that's true, because it's involving our what? Intrinsic muscles of the hand. So our answer should be what? The D, right? So because we are looking for what? Concerning brachial plexus, which of the following facts are, it's asking about the true facts. So what are the true facts? That is false. And most common site of injury is upper trunk. That is true. Injury may occur during breech delivery. That is true. Radial nerve is of medial cord. That is false. And lower trunk injury results in hand deformity. That is true. That means true statement are B, right? True statement are B, C, and E, right? So they're asking over the true statement. So hope you understand. Thank you very much for watching, and keep following my YouTube channel. Thank you.